So if you're dealing with mast cell activation syndrome, there's a lot of different strategies in which to stabilize symptoms. A lot of it has to do with like stabilization of the mast cells, reducing histamines, reducing triggers, and things like that. But if you think about this in like a framework this way, where you have the faucet of like the different mediators that the mast cells are creating, like histamines, leukotrienes, prostaglandins, that sort of stuff, and then you have the bucket of whenever the bucket gets too full, then you have symptoms, and then you have the drain that drains out the bucket. There are actually multiple ways that you can deal with reducing symptoms in the context of mast cell activation syndrome. Hi, I'm Dr. Joyce Knieff. I'm a naturopathic doctor, and I see a lot of chronic complex illnesses like mast cell activation syndrome. And this is sort of a way that we can approach the treatment and management of mast cell activation syndrome, in which we're addressing different things here. So the faucet management is oftentimes the most commonly reached for. So it's the one where we're using antihistamines, we're using mast cell stabilizers, we're decreasing triggers, low histamine diet, that sort of thing. That's the faucet. We're decreasing the amount of mediators that the mast cell can produce, or we're blocking the receptors that recept for the mediators that come out of mast cells. There's the strategy of like coming down to the drain too, which is helping us be able to metabolize the mediators that the mast cells are creating to reduce symptoms. And a lot of the times this type of problem happens in people who have histamine intolerance. So they don't tolerate histamines very well because they can't break down histamines very well. So this is where things like optimizing the cofactors for like the DAO enzyme endogenously or the HNMT enzyme to help people be able to break down histamines a little bit better. We can also help people be able to like manage their prostaglandins or leukotrienes a little better as well. So that's a strategy in terms of the management of helping the body be able to deal with the consequence of mast cells dumping their stuff out into your body and causing symptoms. I think another overlooked strategy is like the actual capacity of the body. How much does it take before your body starts becoming symptomatic? This metaphor crosses a little bit over into sort of the trigger happiness of the mast cells as well, which is technically a little bit of a faucet thing too, but the capacity in which your body can deal with inflammation is also one aspect that I think is really important. If you have a body that's also got like high inflammation from other sources already, then having any amount of like pro-inflammatory mediator dump into that bucket already may be enough to cause you symptoms. Addressing things like lifestyle, sleep, any other conditions that may increase inflammation, these are also really important in helping the body have just a little bit more capacity to deal with whatever the mast cells are doing. And so here's a little bit of a chicken and egg thing, because a lot of the times mast cells can become more trigger happy when somebody's capacity is already pretty much full. And if we can lower the inflammation in the body by increasing the body's capacity to be able to deal with inflammation, a lot of the times that like goes back to the faucet piece, because it allows the mast cells to have like a higher tolerance before it gets triggered. While a lot of the faucet things would be like reduction in triggers, antihistamines, mast cell stabilizers, capacity pieces may be things like nervous system work, making sure other conditions are managed appropriately, things like thyroid conditions, autoimmune conditions, making sure that like cardiometabolic conditions are managed appropriately to kind of like decrease whatever is going on in the capacity bucket. Making sure that diet is appropriate, people are sleeping enough, getting fresh air. So a lot of the foundations for health stuff will increase your capacity. And then from the drain perspective, a lot of the HNMT and DAO work and like the methylation stuff, making sure that your detoxification is working appropriately. This is like gut work, liver work, detoxification, optimization, making sure that all of your enzymes have cofactors, and this is where we can look into like genetic SNPs and stuff just to make sure that you are having a lifestyle or like supplementing that is in a way that's appropriate for your genetics. So different levels of like strategies here. And I think when it comes to these strategies, sometimes the timing of things is kind of important. I did write up a free guide on when you first get diagnosed with mast cell activation syndrome, or if you think that you have mast cell activation syndrome, there's like a bunch of information and there's like things that people start doing that just might not be super helpful. So I've got a guide that's free in the area where you find the things. Hope this was helpful. So I think the problem with finding a good doctor for treating mast cell activation syndrome is that mast cell activation syndrome is such a complex and rare condition. It's getting to be more common post-COVID, but traditionally it's been much more rare and we aren't taught a whole lot about it, that a lot of the doctors who see it are kind of just stuck on the diagnosis part of it. A lot of them aren't really looking further into the treatment aspect of it. So in terms of getting a diagnosis and getting the lab tests you need done, I think going to an allergist or a rheumatologist, these are good bets to get that diagnosis, and maybe even getting medications that will work for you. But in terms of finding someone who's going to untangle this whole mess that's happened to your life because of the mast cell activation syndrome, you really want to look at a doctor who will work with you more on an individual basis. And most of these doctors I see as naturopathic doctors or practitioners of functional medicine. And even in that scope, even in naturopathic medicine and in functional medicine, I think it's still important to find someone who is willing to both listen to you and work with you over a long term instead of just, seeing you once or twice. So as much as this sucks, I think this is really going to be the type of doctor that really has more of a limited patient panel so they know who you are and you're not just like one of the 2,000 people that they see once a year or something like that. So while expertise of a doctor is really important, I think what is also really important is the willingness of a doctor to kind of step up and develop a treatment plan for you. And I think what's also important is finding a doctor who can kind of like trace the biology and like the biochemistry that's happening in your body and make individual recommendations based on what you are dealing with, not just what your diagnosis is. Because again, even if we're just looking at the pharmaceuticals of mast cell activation, there's like antihistamines, mast cell stabilizers, leukotriene antagonists, and biologics. And these are not all applicable to all people who have MCAS, because not everyone who has MCAS maybe has a leukotriene problem. Not everyone who has MCAS maybe has a prostaglandin problem. These are all different and need to be tailored to what is going on specifically in your biology. And I think this is even more important if you want to work more towards a goal of repairing your body systems rather than just managing them. And I say that because I know with something like mast cell activation syndrome, a lot of these medications and a lot of the traditional like supplements that we give that are mast cell stabilizing, like vitamin C, quercetin, luteolin, all of these things, what they're doing is trying to stabilize the mast cells. Whereas we could do better with medicine. We could ask, why are the mast cells overreacting? Why are they overreacting? What is causing these symptoms to spiral so much out of hand for these patients? And what can we do in terms of improving the organ function or improving the resilience of your biology to make it so that your mast cells are more stable from a systemic level rather than just like a suppression level using these individual agents, whether pharmaceutical or natural. And this is the piece that I'm like really passionate about, right? Because like we know a lot, there's a lot that we still don't know, but we already know a lot about what immune regulation needs and like what we can do to promote immune regulation or to like promote organization of our different organ systems and like recovery of things. And why aren't we doing that? Like we know that there's so much control over the body's nervous system, the body's immune system, just by modulating your gut health. That's the thing that we know. It might take longer. It might take more of like a strategized sort of treatment plan instead of just like one prescription for this long and then another one for this long. It might take like looking at how this patient responds to these different protocols and running labs along the way, but it's something that is doable. So, long answer short, I think getting a diagnosis is one thing. And like, if you can find someone who will run those tests for you, allergist, rheumatologist, your primary care doctor, if you discuss your symptoms with them, they should be able to run the tests for you and match up the criteria for you. But if you're really looking for someone who can help you sort out this mess and really fix it from like a systems level and try to get you to the best health that they can given the limitations that you have, the type of doctor is less important than the willingness of the doctor to learn and work with you over a longitudinal period of time. Does that make sense? I hope that helps. Thanks. Let's do a diagnostic workup for mast cell activation syndrome. So one thing that you have to understand when a doctor is doing a diagnostic workup is that they're going to look for the most common condition that explains your symptoms. And in the vast majority of cases, mast cell activation syndrome is a zebra, so a lot of doctors are going to look for horses first. And these are going to be your rule-out conditions. You're going to find the conditions that might explain your symptoms, but don't completely explain your symptoms, or the lab testing doesn't match. And so these are going to be the rule-out conditions. Your doctor is going to look at these first before they consider mast cell activation syndrome. So in terms of rule-out conditions, you're likely going to have a doctor rule out these conditions first with most common presentations of mast cell activation syndrome. So you want them to rule out hereditary alpha trypsinemia. This is also called HATS. Carcinoid syndrome, Pheochromocytoma, medullary thyroid carcinoma, or any other thyroid issues. A lot of weird sort of cancer tumor issues with weird secretory patterns can result in a mast cell activation syndrome type of presentation. So you want to make sure that you're ruling out these conditions first. And these are fairly easy to rule out by lab testing. MCAS is hard to lab test for. These are easier to lab test for or use like imaging to rule out. Other things that should be tested in a comprehensive workout would be vasovagal syncope, idiopathic anaphylaxis, IgE allergies, autoimmune conditions, and chronic infections. And these are things that can explain some of the symptoms of MCAS. They are not mutually exclusive with MCAS. So those are just pieces to pay attention to. You can have one of these things and also have MCAS. This is a good comprehensive lab workout to start off with. We all know about serum tryptase. Again, if your serum tryptase comes back low at baseline, this does not mean you do not have MCAS, because in the diagnostic criteria of MCAS, you have a stable baseline serum tryptase that elevates 20% plus 2 nanograms per deciliter during a flare. So you've got to get a baseline serum tryptase and also have a serum tryptase within 4 hours of a flare condition. If you have a high serum tryptase at baseline, that rules in HATS. So that's a really important piece just to get anyway to figure out what you have. 24-hour urine metabolites are sort of the easier way to catch MCAS markers without having to catch serum tryptase during a flare. So like histamine metabolites, this is like N-methylhistamine. You've got urinary prostaglandin D2, urinary leukotriene E4. Now, this urinary leukotriene E4 is a good one to pay attention to because this can inform treatment. Because if you have this, more than likely Singulair or montelukast will work for you. A leukotriene antagonist as a medication will work for you better than if you didn't have this be elevated. Other urinary markers include like 11 beta prostaglandin F2 alpha. You also want to look at just a basic complete blood count with differentiation, because this will point you towards chronic infections. If your white blood cells are high, this will point you to any other weird, funky things of anemia that might be happening, which can happen with iron deficiency or B12 deficiency, or some weird like leukemia type things. The CBC will tell you that. And then you want a comprehensive metabolic panel too, to check on liver and kidney function, as well as some electrolyte function too, because if your liver and kidneys are not okay, that's going to give you a lot of funky symptoms as well. So always good to check on the basics here, just to rule out any of the obvious things that could be happening to your organ function. And then you have your serum Chromogranin A and urinary 5-HIAA, and this is to rule out the carcinoid syndrome up here. Up here. I can't see. Right there. And same thing with the plasma urine metanephrines. You're ruling out Pheochromocytoma. Say that. Try saying that fast. And then you want to rule out the medullary thyroid carcinoma with some of these thyroid function tests and calcitonin. If you want to look closer at other thyroid issues, I would suggest expanding this thyroid panel. This is just the very, very minimum. You want a TSH, you want a free T4 and a free T3. I also like looking at total T4 and total T3 as well to get a sense of that protein binding of that thyroid hormone. But also things like thyroid binding globulin, TBG, and reverse T3 are ones that are good to look at as well as some of the possible autoimmune antibodies like TPO, TG. If you're looking at more of like tachycardia and other types of mimicking symptoms for like a hyperthyroidism, then you want to look at TSI and thyroid receptor antibody as well. You also want to look at allergy testing, again, for that IgE mediated thing, skin prick testing or specific blood testing for IgE types of antigens. You want to take a look at that too, just to see whether or not the IgE has any play within all of everything that's going on. You also want to run an ANA with reflux. This is just basic ruling in, ruling out for autoimmune conditions. This down here in the light blue, this is stuff that I like looking at that maybe is not as common for other doctors to look at. I like looking at a vitamin D because of its role in immunomodulation, iron panel with ferritin, and this mostly helps me interpret this CBC as well, because in the CBC, this gets a little bit more complex, but if your blood cells are really, really small, then you're usually iron deficient. If they're really, really big, then you're usually some sort of B vitamin deficient, or you have methylation difficulties. But the size of your red blood cells doesn't always say as much, because if you have both iron deficiency and B12 and methylation deficiency, which happens a lot in chronic disease, your blood cells could look normal, but you're still deficient. So I always like to have an iron panel here just to tell me whether or not you are also iron deficient. Your blood cells look fine, but that would also mean that you have B vitamin or methylation issues. I like looking at an EBV panel with early antigen D antibodies, just to see whether or not there's like a reactivation EBV type situation going on in terms of those chronic infections. I like looking at a CRP, a SED rate, to further assess inflammation, and a celiac panel here, especially with GI manifestations. It is a really good idea to just kind of take a look at and rule out and make sure that's not happening. I know that was a little bit of a whirlwind. I tried to speak as quick as I can because I know these videos have to be very short to keep people's attention spans, but hopefully that is a good list to start out with. And it could be a good list to bring to your doctor and try working out, just to see if you can like rule out some of the main rule out conditions for mast cell activation syndrome, so you can arrive at a diagnosis that gives you the best treatments for what you're dealing with. Thank you for paying attention the whole way. If you don't know me, I'm Dr. Joyce Knieff. I see a lot of complex chronic issues in my clinic, and follow along if you want to learn more. Thanks. Yeah, so tryptase and mast cell activation syndrome. Tryptase is one of those tests that's really important to test for with mast cell activation syndrome. It's considered one of the most turnkey pieces of the criteria for diagnosis for mast cell activation syndrome. It can also help in diagnosing other conditions like HATS, which is a hereditary elevation in tryptase. So the key for testing tryptase for MCAS in particular, mast cell activation syndrome, is that you have to both have a baseline test and a test within 4 hours of when you have a flare. And to meet that specific criteria for mast cell activation syndrome is your baseline tryptase will probably be normal, but when you have a flare, your tryptase, if it elevates at least 20% plus 2 nanograms per milliliter, that's a little bit arbitrary, but if it does have that increase, then that meets criteria for MCAS, as opposed to HATS, where you'll find that your tryptase is possibly elevated all the time. So yeah, understanding when you are testing the tryptase and how to interpret that is also really important in the differential diagnosis of some of these allergic related conditions. But best of luck with that testing with your hematologist. Make sure that he or she knows all of that, and yeah, get diagnosed, figure out what's wrong with you, and get on with treatment. Do you have mast cell activation syndrome? Put a finger down version, criteria 2. Put a finger down if you have had burning and or cramping abdominal pain of unknown cause and or reoccurring or continuing diarrhea, also for unknown cause, and or frequently intense gassiness independent of diet with or without accompanying nausea. Put a finger down if you have had episodically occurring burning and or choking chest pain attacks, which are often experienced as life-threatening, and any EKG that you get shows that things are normal. Put a finger down if you've had bladder pain or pelvic pain that's accompanied by the painful desire to always void your bladder, but you never have a UTI. Put another finger down if you have constant feelings of burning in your skin or pins and needles and or numbness in random areas, and this does not respond to treatment by any sort of pain medication. Put a finger down if you have skin flushing, hives, random itching or swelling of your skin randomly but episodically. Put another finger down if you have fatigue so bad, fatigue attacks, that you literally cannot open your eyes and all of your other hormones are mostly normal. Put another finger down if you have episodes of low blood pressure where you faint or have near fainting episodes and your heart races in ways that it feels like you're having a panic attack. Also put a finger down if you have dermatographism, which is where you draw a line on your skin and then a few moments later it starts showing up like a hive and is very itchy. If you've put more than 2 fingers down on this first hand, then congratulations, you've met the major criteria of consensus 2 criteria for diagnosis of MCAS. Now we're going to go over to the second hand over here. Put a finger down if you've ever had a bone marrow biopsy or any other biopsy of any other organ that have found there was abnormal morphology or any abnormal conglomeration of mast cells. I'll talk about this one a little bit more, but if you've ever had a colonoscopy or an endoscopy and they've done a biopsy, you can go back and ask the lab to look at it to see if there's any histological evidence of mast cells. Put a finger down if your mast cells in the bone marrow biopsy have shown any sort of abnormal surface proteins like CD2 or CD25. Put another finger down if they've detected any sort of genetic change in the mast cells from the blood, bone marrow, or those biopsies from any other organ. Put another finger down if you've ever had a baseline tryptase measured and then a tryptase measured during your flare, and the flare one was shown to have 20% increase plus 2 nanograms per milliliter from your baseline. Or you've had a N-methylhistamine in your urine that was shown to be high, heparin in the blood, Chromogranin A in the blood, or other mast cell specific mediators like leukotrienes and prostaglandin D2. Put another finger down if you've ever taken antihistamines or mast cell stabilizers and have found that these make the symptoms on the first hand go away. If you've put any fingers down on this other hand, congratulations, you've now met one minor criteria of the consensus 2 diagnostic criteria. This establishes a diagnosis for MCAS. And this is based off the consensus 2 criteria that was put forward by Afrans and Molderings et al. First in 2011, and then it was revised in 2020. The revision in 2020 adds the last minor criteria, which is that the response to an antihistamine or a mast cell stabilizing agent counts as a minor criteria towards the diagnosis of MCAS. Now, this is widely criticized as the consensus criteria that is easier to meet the diagnosis of, which can promote overdiagnosis, which is why if you're using this diagnostic criteria, ruling out of conditions is really important. If you'd like to know more, if you'd like your doctor to know more, I recently came out with an online course, the link is in my bio over here, that is on the diagnosis and management of mast cell activation syndrome. It goes over the diagnosis of mast cell activation syndrome with all the criteria in the last decade and the most recent revisions of that criteria, as well as the diagnosis, as well as the management, both in pharmacological agents and in natural agents. Do you have mast cell activation syndrome? Put a finger down version. Put a finger down if you have chronic skin allergic manifestations like chronic itching, chronic hives, or flushing, or like very painful red swelling of your skin. Put a finger down if you've had chronic nasal congestion, feels like you have sinusitis all the time, the inside of your nose itches, you have wheezing, chronic cough, or asthma symptoms that you can't seem to get under control. Put a finger down if you have hoarseness, constant reflux, abdominal cramping, bloating, diarrhea, and the like. Put a finger down if you have low blood pressure and fainted or near fainted because of it, if you have headaches all the time, and your heart seems to race. Put a finger down if you've had recurrent, unexplained episodes of anaphylaxis. If 2 or more of your fingers are down, go to your second hand. The second hand is when you go see your doctor. Has your doctor run a baseline serum tryptase for you and also run one during your flare and have found that the one during your flare was 20% above your baseline plus 2 nanograms per milliliter? Or has your doctor run a 24-hour urine N-methylhistamine, prostaglandin D2, or 11-beta prostaglandin F2 alpha, or leukotriene E4 and found any of those to be elevated? Or have they run a plasma histamine and any of the histamine metabolites and found those to be elevated? If any of those are true, put a finger down. Has your doctor prescribed antihistamines or mast cell stabilizers, and when you took them, especially after 2 to 4 weeks, a lot of the symptoms on the first hand started to go away? Put a finger down if this has happened. If you have these 2 fingers down, then congratulations, you have just met the diagnostic criteria for MCAS, mast cell activation syndrome, as proposed by Valent et al., and this is known as the consensus 1 criteria. There's another criteria that is currently used to diagnose MCAS that I will cover again in this format. But just know that consensus 1 is considered the more stringent criteria for diagnosis of MCAS. So if you don't meet this criteria and you have a high suspicion, go check out consensus 2 criteria. Those of you who are new here, hi, I'm Dr. Joyce Knieff. I am a naturopathic doctor. I practice in the state of Minnesota, and I just came out with an online course that covers the specifics of diagnosis and management for MCAS, including diagnosis, pharmaceutical treatment, natural agents, and dietary interventions. So check it out. I've made the diagnosis part completely free, so if you want to present this to your doctor and have a discussion over it, feel free. Here are the 3 different types of MCAS. There's primary, secondary, and idiopathic. Hi, I'm Dr. Joyce Knieff. I am a naturopathic doctor practicing in the state of Minnesota. So the primary type of MCAS is also known as the clonal type. This is where there's something genetically abnormal with the mast cells themselves. There's a condition called systemic mastocytosis that falls under this category. Usually genetic testing or bone marrow biopsies can really catch this type of MCAS because there's some sort of genetic abnormality that's going on. And the most commonly known one is the KIT D816V mutation, so that's how that's looked at. The secondary form is when there's a known trigger that triggers the mast cells and the mast cells are overreacting. So this can be reactivity by the mast cells from something like an IgE-mediated thing, infections, or autoimmune disease. This is a little bit different from the type 1 hypersensitivity that is a plain IgE allergy, because with mast cell activation syndrome, you do have manifestation in 2 or more organ systems. So if you do have an IgE thing and you are symptomatic with symptoms in more than 1 organ system, then that IgE-mediated reaction could be considered secondary MCAS. And then you have idiopathic MCAS, which is the most common presentation in clinical practice. The idiopathic MCAS is the case in which we cannot identify a cause. You test the mast cells; they're genetically normal. It's just that for some reason they are overacting for an unknown cause. And knowing the types can really inform treatment, because if you have a genetic or clonal type of primary MCAS or systemic mastocytosis, then this is an area where you really do need to have a lot more symptom management therapeutics on board, because the mast cells themselves are genetically abnormal. So you do have to keep that in mind while you're deciding treatment. You're trying to stabilize those mast cells. You're trying to lessen the effect of histamine and other mast cell mediators to make sure that the inflammation in the body or the flares are kept as low as possible. In primary MCAS, there isn't really a cure because it is genetic. It's difficult to make the mast cells not be abnormal because of the way that they've been produced by your bone marrow. Now, if you have a secondary MCAS, then you know that there's a cause to that reactivity. What you can do is go address the cause or address the reactivity. Like, symptom control is still very important in this case, but if you have an autoimmune disease or an infection, you can always address the autoimmune disease or the infection to try to modulate the symptoms of the MCAS later down the line. And I think the idiopathic MCAS is the most exciting one because, again, there's nothing genetically wrong with the mast cells. There's no trigger that is known, which can be frustrating for some people, but this is where functional medicine and naturopathic medicine can come very intensely into play. Because if this type of MCAS has been developed because of some sort of immune system dysregulation, then we can really target the systems that help with immune system regulation, whether or not that's addressing gut health, whether or not that's addressing underlying infections or exposures to environmental toxicants. We can really do a lot to help the immune system just come back under regulation and perhaps lessen the effect of this idiopathic MCAS. So those are the 3 types of MCAS and why they matter, because they really inform treatment. I hope that helps. Click some of these buttons if you found that helpful, and leave a comment if you found this interesting or if you have further questions. Thanks. There are 2 consensus criteria for the diagnosis of mast cell activation syndrome, and I've talked about each one of them as individual videos on my channel a few times here. And I think they're just worth talking about because the diagnosis of mast cell activation syndrome is still so complicated and a lot of people don't know sort of the nuances that go into the diagnosis. Hi, I'm Dr. Joyce Knieff. I'm a naturopathic doctor, and I see a lot of chronic complex conditions like mast cell activation syndrome. So as a Cliff Notes, Consensus 1 criteria for the diagnosis of mast cell activation syndrome is very often criticized as being too stringent, and Consensus 2 is very often being criticized as being too lax. Consensus 1 is the typical one where the second criteria is needing to match the lab diagnosis criteria of having a baseline tryptase that is a normal tryptase, and then a elevated tryptase during a flare that increases 20% plus 2 nanograms per deciliter. I think the most recent updates to Consensus 1 have started including other testing options like the urinary markers, Chromogranin A, and like histamine metabolites and that type of stuff. But in general, for Consensus 1 criteria, which I think is the one that most big associations go by, is the one that you have to meet all 3 criteria to be able to meet diagnosis of mast cell activation syndrome. Now, because a lot of testing in mast cell activation syndrome is difficult to catch and annoying to get, or just like not as sensitive as we want it to be, Consensus 1 can be difficult to meet all 3 criteria of. Meanwhile, Consensus 2 has a major criteria and 6 minor criteria, and all you have to do is meet the major criteria and one of the minor criteria to establish diagnosis. This is commonly criticized as being too lax because really you only have to have symptoms, and then there's one minor criteria in the most updated version, updated in 2020, that as long as you have like a response to mediator therapy, which is like antihistamines, mast cell stabilizers, that type of thing, if you have a response to mediator therapy, then just meeting that major criteria and that minor criteria gets you diagnosis, which a lot of people criticize as being too lax, because then if you just have symptoms and you take meds and it works, then you meet the diagnosis, which if that is all you're doing and you haven't ruled out any of the other conditions that could produce those symptoms and could produce that improvement by taking medications, then you're really doing a disservice to your patients. There's also a criticism around like the heterogeneity of like the condition and which narrow pieces of this condition should we allow into like the diagnosis so that the research at least is like robust and we're more able to research this condition in a way that people presenting with a certain way, we know exactly how to treat them. Whereas if we have a very broad diagnostic criteria, then we maybe have a bunch of different presentations that may all react differently to different like therapeutic approaches, and then we don't know what actually works for every individual narrow presentation of things. So this is kind of like the discussion in terms of how do we decide diagnostic criteria? Do we want a narrow diagnostic criteria so we get mostly people who look and respond the same way in terms of their symptoms and how they respond to treatment? Because if we can get a narrower window, then this population would be easier to research and easier to get good therapeutics that we know work well, rather than looking at people who like have a very broad presentation and then we're applying the same therapeutic and getting very different responses. Then we don't know what works for anyone. So Consensus 1 criteria is very narrow. It is very research focused and like very, very much like we want people who look this way to be categorized as mast cell activation syndrome. That way we know exactly how to treat them, exactly how they respond, and what therapeutics we can develop. Versus Consensus 2 is more like it's broader. We get much more overlap of that, like people who have unconventional presentations, which with like mast cell activation syndrome, that's just kind of a thing because the way that your mast cells respond to things can be very, very individual. Mast cells release a lot of mediators, not just histamine. So it can be like histamine dominant symptoms, but there can also be leukotrienes or prostaglandins and all of that sort of stuff. You can have neurological symptoms. You can have primarily gastrointestinal symptoms or primarily cardiovascular symptoms. It just is like a very heterogeneous population to begin with. So with Consensus 2, we're encompassing a lot more people, which like in in the philosophy of clinical practice, that may allow for more people to actually get the treatment they need, especially with like the system of medicine that we have, which very oftentimes requires you to have a diagnosis in order for like doctors to actually even do anything or get you any sort of disability or like insurance coverage for things. So in that sense, like consensus 2, I feel applies to like the humanities of medicine and like actually taking patients seriously for like what they're presenting with and what they're struggling with in their condition. But you know, these two things are very difficult to reconcile, right? I think mostly for consensus 2, I think I believe that patients should be believed, and if you meet criteria for consensus 2 after a robust workup with your doctor ruling out other conditions, then you should be able to get a diagnosis and be able to seek treatment, be able to seek social support for this type of condition. But at the same time, I understand that like having a heterogeneous pool of people who have this condition is difficult to research. So that is the difference between consensus 1 and consensus 2, and sort of what's behind the debate on which consensus criteria to go for, and whether or not this is a matter of like gatekeeping the diagnosis or not. In an ideal world, I think we would be better about really identifying like the subtypes of certain diseases. But right now we just don't have like that funding for research, that funding to like do these types of population studies. So this is kind of the best that we have. Hope that clears some things up. Yeah.